A very good afternoon, everybody. Respected chairpersons, my teachers, and dear friends. At the outset, I thank ISNSC for giving me this opportunity. The topic is nutritional challenges in acute kidney injury. Very limited literature in AKI with plenty of literature in the area of CKD. So when a patient critically ill patient develop acute kidney injury, that leads to significant changes in the metabolism of carbohydrate, protein, and lipids, leading on to a hypercatabolic state, hyperglycemia, and impaired lipolysis, completely altering your milieu interior. It is very prevalent, malnutrition is very prevalent in critically ill patient, contributing to important risk factor for mortality in a ill patient. This is a study published in Kidney International. The left-hand side, ill patient who has no AKI at all, and on the other side, an AKI on renal replacement therapy, contributing to 60% increase in the mortality of these patients. And there are several retrospective, prospective, observational studies showing that the negative nitrogen balance, malnutrition, low BMI, everything is contributing to increased mortality and even 1-year mortality in patients with CKD, in AKI. Now, what are the probable causes for these patients to develop AKI? Right from the pre-existing poor nutritional status to the loss of nutrients in the dialysis during kidney replacement therapy. Several reasons for these patients to go ahead with a malnutrition states while in ICU. So this is, why should we address this nutritional status at all? We have several other areas to give concentration. But still, a good nutrition will improve the immunity, will improve the wound healing, overall improve the survival of your patient. It will preserve your body mass. It will help you to maintain the fluid balance, electrolyte balance, etc. But still, we know that AKI is not a single disease process in an ICU. It is most likely a complication of a critical care illness. Most likely a complication of a post-operative period. Most likely a complication of a sepsis. So it is the cause of AKI is different in different patients. Severity of AKI is different in different patients. One patient may be on KRT, other patient may be only on supportive care. So the cause, the individual patient is different. So we have to plan accordingly. So there are several challenges to plan nutrition in AKI versus a chronic kidney disease. So a nutritional therapy should start with screening for nutritional status, assess the nutritional status, and then plan individually. How to screen? The screening, as per literature, it should be done within 24 hours of hospital admission. And why should you screen? You have to identify those who are malnourished already, or you have to identify the risk factors, those who are at risk for developing malnutrition. Several screening tools are available in the literature. The latest of introduction being the Nutrix score, RNST score, INET score, etc. Several scoring systems, but very cumbersome to calculate in an ICU critical care setup, especially in those with kidney impairment. It's not that validated in those with kidney failure. So now we are going to assess the nutritional status. We know that there are several signs and symptoms of malnutrition, right from loss of body weight, anorexia, etc., etc. Several anthropometric measurements are available. Several biochemical parameters are available. Several assessment tools are available. But none of these tools are applicable as a single parameter to assess the nutrition in a patient, especially in those with renal dysfunction. Dynamic nature of the AKI. Today, patient may be on conservative treatment. Tomorrow, he is going to hypercatabolic, initiated on dialysis. So day by day, the spectrum changes. So you have to assess very frequently the nutritional status. And there are no randomized, well-conducted trials are available in AKI. In CKD, plenty of them are there. But in AKI, literature is very scarce, and hence the recommendations are based on observational studies and experiences only. Now, the common parameter that we use is the body weight to assess the nutrition. But is it reliable in AKI? Never. because every day the volume status changes. Today patient may be hypovolemic. Tomorrow he become edematous. Next day initiated on KRT. Everything changes the body weight very frequently, and hence to calculate the various doses of drugs or supplementation, they recommend us to use the actual body weight, edema-free weight on admission, or the ideal body weight to get a BMI of 23, taking into the height of the patient. So these are the weight to be used for calculations. BMI, extrapolation of your weight is also not that good, but a low BMI of less than 18.5 is considered as a marker for malnutrition, but still it is considered as a predictor of mortality than a malnutrition. Going on to the nutrition-focused clinical examination, looking into your muscle strength or your other parameters, again masked by edema, not useful. Anthropometric measurements, your tricep skin fold thickness, your mid-arm circumference, hand grip strength. All these are also limited by age, gender, edema, and there are no standardization of anthropometric measurements in acute kidney injury. So these are also not that reliable to assess the nutrition in AKI. This is the muscle strength, skeletal muscle strength assessment by a muscle ultrasound or a CT assessing the muscles at L3 vertebra. They are recognized by the MRC to assess the ICU acquired weakness, not for the baseline malnutrition. Bioimpedance analysis, not validated in patients with AKI on KRT. DEXA, gold standard for assessing the body composition, but influenced by the hydration status. So it is also, its cost also. So cannot be utilized routinely for day-to-day practice. Several biochemical parameters. We routinely do all these during our daily clinical this one. Serum albumin, most commonly used biochemical parameter. Is it useful? T-half itself is 20 days. What is the point in assessing the nutrition in an acute setting? Changes its concentration depending upon the body fluid compartment change, fluid status. It is an osmotically active agent, all influenced by inflammatory state. So albumin is also not that reliable in acute setting, but still a less than 3.8 gram is considered as a marker for malnutrition. And increase in albumin by 1 gram increases the survival of acute ICU patient by around more than 20%. So it is more useful to predict the mortality in an ICU rather than assessing the nutritional status. Serum cholesterol, ISRNM now recommend to include serum cholesterol as a marker for nutrition, and less than 96 milligram is to be considered as a pointer for malnutrition. Pre-albumin, shorter half-life, but it is excreted by the kidney. So what is the point in using that in an AKI patient or a patient with kidney impairment? IGF-1 has a good correlation with the nutritional status because of its low stability, shorter half-life, etc. But there are only very limited data to use this in clinical setup. The nutritional assessment tools are commonly used are the SGA and MIS score, subjective global assessment. Most of the data is from CKD, well used in CKD to assess the malnutrition, but it is not validated in AKI. Subjective, malnutrition inflammation score, MIS, adding some more biochemical parameters into your SGA, that's all. Again, it is not that useful because you have several parameters, biochemical parameters as required, and expertise is required to assess the malnutrition inflammation score also. So these are the summary of various assessment tools available. None of them are that useful in a critically ill patient in an ICU setup. Most of these parameters have their own limitations when it is applied in AKI situation. Going on to the nutritional requirement part, then what are the challenges? Most of the patients are catabolic. So your routine assessment will not be sufficient. Most of them require your judgment into the baseline comorbidity. Most of them will be having some other comorbidities. The type of dialysis also influences the nutritional requirement. So all these has to be taken into account when you plan the nutritional support for an AKI. Energy requirement, usually it is 130% of the resting energy expenditure. Resting energy expenditure ideally should be calculated by an indirect calorimetry, which is not practical and not available. So you have several equations are available, which is also cumbersome. And finally, KDIGO recommend, whatever be the status, give 20 to 30 kilocalories per kg per day, whatever be the stage of AKI, of which roughly around 3 to 5 gram per kg should come from carbohydrate and 1 gram per kg, that around 35% should come from fat. This is the final recommendation without any one of these assessment or equations. No increase in requirement of energy for those who are on KRT. But take into account the energy that is added upon by the various constituents in your dialysate. That has to be taken into account. What is permissive underfeeding or trophic feeding? There is an endogenous energy production by around 1400 kilocalories during the critical illness. So whether you have to give allowance to this endogenous production. So this you give only 500 kilocalories per day initially, and this has several advantages theoretically to give less energy during the first week of illness. And this was studied in 2 landmark trials, Eden trial and Permit trial conducted in 2015 and 12, and both have shown that there is no significant benefit in terms of ICU mortality. Even if you give full energy first day or give only trophic feeding or less energy, 7 to 10 kilocalories during the first week of illness. So these are the summary of Eden trial and Permit trial. So final consensus is a critically ill during the first 1 week give only 20 to 30% of feeding goal. That will be roughly around 8 to 10 kilocalories per kg per day. And by the end of 1 week, you slowly increase to 25 to 30 as recommended. And is there any point of higher energy feeding? Is it beneficial? The studies have shown no benefit at all, but it, on the other hand, it increases your hyperglycemia, increases your hypertriglyceridemia and positive fluid balance. So there is no point in giving more of energy to improve the outcome of the patient. The Society for Critical Care Medicine and American Society also recommend almost the same amount of energy during critical illness. Regarding the protein, proteins will constitute roughly around 15% of your total solids in the body. And this is how protein and amino acids is distributed between the cells and the plasma. And we all know that nitrogen balance is an important parameter, at least in patients with renal disease. And you use urea nitrogen appearance or protein catabolic rate to assess the protein breakdown. And a positive nitrogen balance is always welcome in an ICU to improve the survival of the patient. But it requires various complicated equations, which is not practical. Even if you calculate using all these equations, it is not valid, reliable only if GFR is more than 50. So what is the point in doing a patient with kidney impairment? So these nitrogen balance equations are also not helpful in patients with renal impairment. And it is the hallmark, protein breakdown is the metabolic hallmark of acute kidney injury. That is said to be the predominant one. But high protein intake, you ask the patient to have a positive nitrogen balance. Is it worth to give a high protein? It is not worth. All the analysis have shown that it is not worth to give more protein. It only adds to your increased urea and more of uremic symptoms. And you have also to be consider the various losses of proteins and amino acids during various forms of KRT. And taking all these into account, KDIGO recommend you should not reduce the protein intake thinking that you can delay the initiation of KRT. That is a very strong recommendation. And patients on non-catabolic AKI, not on KRT, 0.8 to 1 gram per kg per day. Patients on KRT, little increase to 1 to 1.5. Hypercatabolic or on CRRT, give up to 1.7 gram per kg per day. And European Society recommendation almost the same. The Taiwan Task Force of recent 2021 recommendation, they have given up to recommend up to 2.5 gram per kg per day in those who are on slightly increased protein intake is recommended by the recent guidelines. A plant-dominant protein has some theoretical benefit. We do not know exactly what is the status. Amino acid, separately giving amino acid, you have specific nephro solutions are available, giving specific percentage of different amino acids. But there are no convincing data that amino acid transfusion will improve the morbidity and mortality in ICU. Carbohydrate recommendation 140 to 180 serum glucose. Give at least 50 grams per day to prevent starvation ketosis. And 60 to 65% of total calories should come from carbohydrate diet. This has to be taken into account when a nutritionist plans the diet for a critical ill. Lipids is a concentrated source of calorie. And we saw that 35% of calories should come from fat. And that will be roughly around 1 gram per kg per day. And we have new available SMOF and omega-1, which are the newer lipid solutions available for use in critical ill patient. Electrolyte imbalance, we are all aware of the electrolyte imbalance in those with AKI, and this has to given special attendance when you plan nutrition in those patients. Micronutrients, the various micronutrients, the loss of micronutrients in dialysis, and the recommendation of in patients on CRRT is given, but otherwise give the standard doses of these micronutrients. That is what we can do in a day-to-day clinical practice. Going on to the route of supplementation. The recommendation is enteral route, wherever possible, start within 48 hours. Several benefits of enteral route, but there are some problems in some patients with the GI edema or post-operative laparotomy patients where parenteral nutrition is to be suggested. Is it better than enteral nutrition? Several RCTs have been conducted in this area, but none have proved any benefit of parenteral nutrition over enteral nutrition. And it is recommended to use only if GIT cannot be used. Only if GIT cannot supplement 60% of your energy requirement. Then you start on parenteral nutrition with various solutions that are available in the market. When to start? Day 1 or after 1 week? And this is the famous EPANIC study which looked into early versus late initiation of parenteral nutrition, early or late after 1 week. And they found that early initiation has increased the mortality of ICU. So current recommendation, if at all you plan parenteral nutrition, start only after 1 week. That is the current status. EPANIC study. Intradialytic parenteral nutrition helps you to reduce the fluid intake, give nutrients in short period of time, but data in AKI is not that. So recommendations on critical illness, only enteral nutrition, early enteral nutrition within 24 hours if no contraindication, only 20 to 30% of energy requirement in the first week, not adequately nourished, enteral route is not possible, initiate on parenteral nutrition, that too only after 1 week. Various other solutions like intravenous amino acids, glutamine, PUFA, several of them are discussed in literature, but none has no convincing evidences. So AKI in a critically ill ICU they are a heterogeneous group of patients with widely varying nutritional needs and intakes. High risk of malnutrition they have, and identifying the malnutrition in a critically ill patient is an important, to consider this as an important risk factor for mortality. You have to assess the nutritional status and requirement very frequently during the ICU stay. Avoid underfeeding as well as overfeeding during these days. And in general, there is no high quality evidence in this area in acute kidney injury. So you have to use your own judgment when planning nutrition with the help of actually a nutritionist should be done in an ICU. Thank you.